Numbers 50, 53, 54, 55, and 57, we'll be presenting the case of Henry Moliason. And this is a unique case, it's not in syllabus, so that's why we picked it. So I'll just introduce the timeline. So first, patient Henry Moliason had a bike accident which led to seizures that Rakshit will be covering. I'll be covering the surgery which was conducted to reduce the seizures, and the post-operation complications will be covered by Krishna, and the reasons for the complications will be covered by Afia, followed by the functional anatomy by Krish.
Hello, good morning everyone. Today I Rakshit, roll number 57. Today we are presenting a case which is considered as one of the most remarkable cases in the neurosurgery history. This case is about the patient Henry Moliason. So basically Henry Gustav Moliason, he was born on February 26, 1926 in the Manchester County. He was a normal child like all of us until the age of 8, where a bicycle accident caused the head trauma and the loss of consciousness. Minor generalized seizures, they were started at the age of 10, but as his age progressed, the seizures, they were also progressed to the tonic-clonic seizures at the age of 16. So first of all, now let's understand what are seizures. Seizures, basically, they are the sudden uncontrolled surge of the electrical activity of the brain. Basically, there are mainly two types of seizures, which will So the first one is the tonic-clonic and the another one is the Petit-Mal type of seizures. So the Petit-Mal type of seizures in the primary symptoms include the brief lapses, and its typical duration is around 5 to 10 seconds. And it does not have any major impact on the brain. While the other type of seizure, which is the tonic-clonic or the grand mal type of seizures, its primary symptoms include the physical convulsions and the stiffening. Its typical duration is around 1 to 3 minutes, and its brain impact is lead to the neuronal death. And it can also lead to the sudden unexpected death also. But in our patient, the etiology of the seizures were not very clear, because he has also the genetic history of the epilepsy from his father's family, and also he suffered an accident at the age of 8. So, yes. Despite giving high doses of the anticonvulsants and the anti-epileptic drugs, there was no effect on his seizures. So finally, at the age of 27, he decided to undergo a surgery by the neurosurgeon William Beckler Sowley at the Hartford Hospital, because the medications were failed and the seizures were disrupting his daily life. So thank you. Now I would like to call Krishank for the next part of this.
Good morning again. So I'll be discussing about bilateral medial temporal lobectomy. So first of all, why are we just removing one lobe? Why aren't we just doing a craniectomy? It's because patient Henry Moliason had something called as focal onset epileptic seizures. So what happens is it starts in one lobe and then it propagates to the other lobes by the white matter tracts, like for example corpus callosum. And that's why when people have seizures, usually corpus callosectomy is performed and they are cut so that the seizures don't spread. Okay, so before the surgery, they had to find where the seizures were originating. So they used an EEG, electroencephalogram, which is kind of like an ECG but for the brain. And with that, they localized it to the medial temporal lobe. Scalp incision. So they started from the root of the zygoma, it went up towards the frontal bone and it reached the midline, and this the posterior part of this is not accurate, it's taken from somewhere. Just imagine the anterior part, and that was the incision that they made. And they made like a flap, and care was taken not to cross any major vessels like the superficial temporal artery, and they also preserved the branches of the facial nerve, and they cut it as parallel to the wrinkle lines as possible, for faster healing. Then they made bore holes to remove the plate of the skull, and with that they could access the inner structure. So they've Hello. Yeah, so this is the skin flap reflected. This is the temporalis. This is the bone plate that they removed. It was like a 6 inch by 6 centimeter by 6 centimeter plate, and this is the dura mater. This is not. This is something else from a hematoma other case, but basically they cut the dura mater and they drained out about 50 to 100 ml of CSF, and this was important because since the medial temporal lobe is it's a very deep structure, so they had to manipulate the other structures like the frontal lobe. They had to lift up the frontal lobe to reach there, and when you manipulate structures around, it causes intracranial pressure, and intracranial pressure could cause herniation of the other structures of the brain. So it was very important to lift up this to drain the CSF, and also mannitol was given before surgery. So as you can see here, they've lifted up the frontal lobe to access the temporal lobe. And the lobectomy was not carried out by a scalpel as we do dissection, because it's a brain, it's a very delicate structure. You can just accidentally cut something unnecessarily. So they used a different technique. They vacuumed out the brain structures. They literally removed, like, they were planning to remove 8 centimeters, but they only removed 5 centimeters as revealed by the postmortem. Okay, these are the structures that they removed: the uncus, the amygdala, the hippocampus, and the parahippocampal gyrus. This is the actual brain of patient Henry Moliason, and that is just a normal brain. And this is the parahippocampal gyrus, and this is the uncus. So as you can see in this, the uncus is completely removed, and parts of the parahippocampal gyrus are also removed. And this box here is, when they lifted the frontal lobe, it left a mark there. That didn't cause any issues, but it was just there. So when they removed these important structures like the hippocampus, and it severely affected the memory formation, and it caused anterograde amnesia, which will be taken by Krishna. Thank you.
Good morning everyone, I am Krishna Suhastarde, roll number 55, and I will be presenting the clinical manifestations that were seen after the surgery. After the surgery in 1953, Henry Moliason developed a profound but selective memory deficit. Although the surgery successfully reduced his seizures, but it caused a significant change in his ability to form new memories. The most important one was anterograde amnesia. Meaning that he could not form any new long-term memories. Conversations, people, and his everyday life was forgotten within minutes. He could no longer remember things around him as they were. This caused him to live in constant present. Additionally, he also suffered from retrograde amnesia, meaning that he lost a few years of memory before the surgery, but his childhood memories were largely intact. This showed that that older memory functions are stored differently from newly formed memory functions. But not all his memory functions were affected. His short-term memory was largely intact, and his also intelligence, language were all normal. His short-term memory, he could hold things for a brief period of time as long as he was not distracted. His personality also remained largely unchanged. And the most important one was that his procedural memory was preserved. This was demonstrated by a famous mirror drawing experiment. He was asked to trace a star just by looking at its reflection in the mirror. This was initially a very difficult task, but it could be improved with practice. Over a period of time, he was asked to do this task multiple times, and he improved significantly, and there were fewer errors. But each time he did the task, he insisted that it was his first time doing the task ever. This showed that one's procedural memory and declarative memory were operated by different brain mechanisms. Also, he had difficulty with his spatial memory. He could not navigate unfamiliar or new spaces. He also had a difficulty in learning new environments. There were some mild emotional changes, but his social behavior was quite normal. And those changes were caused due to the involvement of other brain structures. And a very interesting one was that it was his lack of future imagination. He was unable to imagine detailed future events and scenarios. This suggested that remembering the past and imagining the future were somehow related. Now I have a voice note of Henry Molaison.
During a typical day.
See, that's what I don't remember things.
Uh-huh. Do you know what you did yesterday?
No, I don't.
How about this morning?
I don't even remember that.
Could you tell me what you had for lunch today?
I don't know, to tell you the truth.
This shows that he could not remember his daily life around him. So I would like to call Afia to elaborate further why and how this happened.
Respected faculty members and my dear friends, a very good afternoon to all of you. My name is Afia Khan and my roll number is 50. Today I'll be speaking about the reasons behind the clinical manifestations in patient Henry Molaison after his surgery. So, as we learned in the previous slides, 4 main structures were removed surgically from patient Henry Molaison's brain, which were the hippocampus, the parahippocampal gyrus, the amygdala, and the uncus. Out of these 4, the hippocampus and parahippocampal gyrus are mainly associated with memory. The hippocampus works as a memory gateway, which means it takes in new short-term information and converts it for permanent storage. The parahippocampal gyrus sends information to the hippocampus and helps in memory encoding. So when both of these structures were removed, HM's brain could still receive new information, but it could no longer save it into long-term memory. The amygdala and uncus were also removed, but these mainly affect emotion and smell, so they played no real role in the amnesia. So coming to our actual question, which is why did amnesia occur? The real cause of his memory loss was the bilateral removal of the hippocampus and the parahippocampal region, which destroyed the brain's ability to transfer experiences into long-term memory. Henry Molaison had lost the ability to consolidate new declarative memories, which means he could have normal conversations, but if you went out of the room and entered again, then he would not remember that you ever talked to him. This led to anterograde amnesia, meaning he could not form new long-term memories after the surgery. On the other hand, retrograde amnesia is when the patient is unable to recall his experiences and memories which he made before the surgery. So here is a comparison of the normal brain and Henry Molaison's brain, in which we can see the hippocampus and the parahippocampal region has been removed. Okay, so as Krishna spoke about the mirror tracing experiment, Henry Molaison could get better at hand-eye coordination and mirror tracing, even though he had no memory of actually practicing them. This is because the motor skill learning does not depend on the hippocampus. It is rather dependent on other structures of the brain, such as the basal ganglia, the cerebellum, and the motor cortex. This clearly showed that the brain has different memory systems such as the declarative memory and procedural motor memory. Declarative memory requires the hippocampus, whereas the procedural motor memory does not require the involvement of hippocampus, and that is why one system failed while the other stayed completely normal. So this was the reason for the clinical manifestations, especially the amnesia. Now Krish is going to come and explain about the functional anatomy of hippocampus.
Good morning, my name is Krish Panchal and I will be speaking about the functional anatomy of the hippocampus. We will be discussing the structure and function together so that we can relate more to the case and understand what actually happened when the structures got removed. We will also study about the connections of them. Now, firstly we will discuss the uncus. Uncus is the hook-like medial projection of the parahippocampal gyrus. It is like the continuation of it. Now the functional connections of uncus include the olfactory processing. As we saw earlier that the uncus is involved in smell-related functions. Now the uncus is highly seizure prone. This is why the patient HM was experiencing so much epileptic seizures. Now olfactory processing, because of the olfactory processing, it receives main afferents from the olfactory tract. It also gives efferents to the hypothalamus, the hippocampus and the amygdala. Now how does it do? Like it tags the emotions with the experiences that happened that day with the odor. Now, for example, if we take the example of the exam day, we are too much stressed and someone just passes by with a nice perfume or something, and now we will relate that stress to the perfume smell. Like whenever after weeks or months, when we again smell that perfume, we will again experience the same stress that we experienced on that exam day. Now we will talk about the amygdala. This is the second structure that was removed during the surgery. Now the location of the amygdala is near the temporal lobe, like close to the temporal pole, which is the anterior most part of the temporal lobe. The main connections of amygdala include the hypothalamus and the medial dorsal nucleus of thalamus. The hypothalamic connections are bidirectional, while the medial dorsal nucleus is unidirectional, which ultimately projects to the cerebral cortex. Now, because it is connected to the hypothalamus, we know that hypothalamus is mainly responsible for secreting the hormones. Therefore, amygdala is responsible for linking the emotions to the autonomic responses. And the corpus striatum is the second connection of the amygdala. In the corpus striatum, the main efferents are to the nucleus accumbens and the basal nucleus of Maynard. This connection includes the function of emotion, motivation, movement, which means that when we experience some emotions, we sometimes get motivation. Now the actual task to initiate those movements through the motivation that we get is the function of the amygdala. Now I will be discussing the hippocampus and the parahippocampal gyrus together because they are intimately linked through a circuit known as the Papez circuit, which is responsible for converting the short-term memory to the long-term memory, which is the main cause of the severe anterograde amnesia of patient HM. Now, hippocampus is located in the deep medial temporal lobe. Now, the main anatomical parts of hippocampus include the head, body and tail, head being the most anterior part as you can see in the picture and tail being the most posterior. Internally it includes the dentate gyrus, which is a serrated structure in the hippocampus, and the cornu ammonis and the subiculum. Dentate gyrus is mainly responsible for the afferents and subiculum is mainly responsible for the efferents, and the cornu ammonis is the main hippocampus guy which actually relays the cycle for converting the short-term memory to long-term memory. The parahippocampal gyrus just surrounds the hippocampus, and its anterior part is called the entorhinal cortex and the posterior part is called the scene and spatial recognition. Now, I will be discussing the Papez circuit. Now, from the hippocampus, the fibers pass towards the mammillary bodies and then to the anterior nucleus of thalamus. Through the mammillary bodies, they pass through the fornix, and from the mammillary bodies, they pass through the mammillothalamic tract to the anterior nucleus of thalamus. Now, mammillary bodies and anterior nucleus of thalamus are just the topographic connections. The main functional connections are of the hippocampal formation and the cingulate gyrus. The hippocampus mainly acts as a relay and modulation center, while the cingulate gyrus integrates the emotions and thinking. From the cingulate gyrus, now the fibers pass to the parahippocampal gyrus through the cingulum. And from the cingulum to the parahippocampal gyrus to the hippocampal formation. The parahippocampal gyrus acts as a gateway between the neocortex and the hippocampal formation. So, if these both structures, the hippocampus and the parahippocampal gyrus, cannot work without each other. Now, what was the reason that the old memories were preserved? Because they were already relayed in this circuit and then passed to the neocortex. Now, why were the new memories not created? Because they did not ever enter this circuit, because the circuit was broken because of the removal of hippocampus and the parahippocampal gyrus. Thank you.